they're not copywritten, and if you've been paying attention, you will see that I've stolen slides from plenty of websites. So, they're in the public domain. They're easy, they're free to take. This gentleman made an interesting point. Probably the first thing I should have said was about conventions of looking at chest x-rays. So it doesn't matter whether the film was taken PA or AP. We always look at chest x-rays as if I am looking at you. So your heart is on my right, and I will always put a film up so that the heart, assuming you don't have situs inversus, where your heart's on the other side, so that the patient's left is always on the observer's right, and the patient's right is always on the observer's left. Okay, so on the observer. So you'll always hang a chest x-ray up so that the patient's heart is on your right. Okay? If you flip it the other way, someone's just going to flip it back and you go, can't do it. Okay. Laterals are different. Depending on where you were trained and by whom you were trained, you may look at a lateral with the patient, look at a lateral so that the patient is facing that way, or the patient is facing that way. And I happen to have been trained where the patient was facing that way, so that's the way I like to look at my laterals. But laterals are easier to look at from either side, but the PA is always done the same way. So it's really important that you make sure the technologist labels the film appropriately right and left, because the technologist will have there'll be a label on the film that says L, what's the patient's left side, what's the patient's right side. But this happens not infrequently. The patient has a situs inversus where their heart is on the right side, and it will just flip internally. But the patient, so the tech is labeled the patient's left, but the heart is on the other side. And now I'm going, did the tech mislabel the study, or does the patient have situs inversus? I hate that because it's always requires a phone call. And are you sure? And are there any priors? So we're not going to talk about that. We are going to talk about. We're going to stay in the chest, and then we're going to branch out through the cardiovascular system. Now, I'm going to get to as close as 5 as possible, and I'm going to go fast, okay? As far as I'm concerned, the stuff we just did is like really the core stuff for today, okay? This is all important, and there probably will be a question or two somewhere on the exam about this stuff. But I want to make sure that you guys understand that what we just did with patient positioning and technique and silhouette sign and air bronchogram sign and contralateral and ipsilateral, I really want you to start to, that's the stuff I really want you to get out of today. So let's talk about cardiovascular imaging. So we're going to talk about the heart and the major blood vessels. And we're going to actually get out of radiography a little bit. We'll look at a couple of other imaging modalities with the way that we evaluate the cardiovascular system. So I want you to be able to, as we've already talked about, recognize the structures that make up the normal cardiac silhouette. We're going to talk about cardiomegaly, the enlargement of the heart, okay, and what constitutes cardiomegaly. And then we're going to talk about a number of other common cardiovascular abnormalities, starting in the chest, but also going into the carotid arteries and the abdominal aorta and the peripheral vasculature and the veins. So we'll get to see we'll get out of the chest by the end of this thing. So how do we evaluate the cardiovascular system? Well, of course, chest radiography is a great way to get an overview of the cardiovascular system in the chest, the heart, and but all you can really tell about that is the size of the heart. And if you're really observant, you might be able to tell which, if any, cardiac chambers are enlarged. But you really don't get you can't see any internal anatomy on the chest x-ray, so you're really kind of stuck. So we have other ways of looking at internal anatomy. We have ultrasound, which is very useful in the heart when we use it with echocardiography, where we can see the valves and the chambers, and we can actually calculate how well the heart is beating and how well it's pumping using ultrasound alone. We have nuclear medicine studies to be able to tell how well the heart muscle itself is working. Is the heart muscle ischemic? Is it getting enough blood? Is it pumping appropriately? So all portions of the heart muscle pump in unison. Do they pump? Do portions of the heart muscle pump well and other portions of the heart muscle not pump so well? You know, we have CT, so we can look at the exquisite anatomy of the heart itself and the blood vessels. We can identify the chambers, we can identify the valves, we can see all of these on CT. On MRI, we can see them really well, but as we get now to CT and MR and nuclear medicine, we get more and more expensive, right? These studies should not be ordered willy-nilly. They're obviously very expensive studies. Some of them are very invasive, especially the catheter angiography, where you get a catheter stuck in your groin and the femoral artery snaked up into your heart and stuck into your coronary arteries and into your cardiac chambers and injected with contrast material. And we take video pictures of that contrast material so that we can see, where the blockages are in the coronary arteries. These things are done all day, every day at Lee and Naples, wherever they're doing open heart surgery, they're doing catheter angiography of the heart. It's a great thing to watch if you ever get a chance, as I'm sure many of you will. It's a lot of fun. It's very cool, as long as you're not the guy on the table. It's great. Lots of different ways that we can evaluate the cardiovascular system. We'll show several examples here. So one of the things you're going to see on every single chest X-ray is going to be a description of the heart size for the most part. Almost every chest X-ray report will describe the heart size. The cardiopericardial silhouette is normal in size, or is enlarged, or that there is something called cardiomegaly. Cardiomegaly is a Latin word which means big heart. So how do we know when the heart is big? The rule of thumb generally is that the heart shadow, the silhouette of the heart at its widest, should be no more than 50% of the diameter of the chest from the inside of one cardiophrenic angle to the inside of the other cardiophrenic angle. So approximately 50%. Lots of longitudinal studies have been done about what constitutes a normal heart. Do I measure every heart on every chest X-ray? No. I look at the thing and I go, heart looks normal. Move on. We don't measure every one, but it becomes a gestalt. So maybe in the earliest days of you guys looking at chest X-rays, you might go, it's a little big. But after a while, you're going to come to look at it and go, you know what, this is big or this is small. Did someone raise a hand? Yes, sir.
What if the cardiophrenic angles are like one you can't see?
Yeah, I mean, you just have to infer it. I mean, it's just, it really becomes a gestalt. Yes, sir.
What the heart has to do with the interior portion of the actual chamber becoming bigger?
And we're going to get to that, but there are two ways the heart will enlarge. Okay. The chambers will dilate, okay, or the heart muscle will become thicker. So there's two distinct processes that cause each one of those, and we will talk about that. So, cardiothoracic ratio, you might hear it referred to as the cardiothoracic ratio. Approximately 50% is normal. Anything over that gets to mild, moderate, severe cardiomegaly. Well, what can the heart become smaller? And only in The Grinch that Stole Christmas will the heart get small. Okay. Generally speaking, if the heart is ever really small, it's really not the heart that's abnormal. But in patients with really bad COPD, the mediastinal shadow will get really long and the heart will appear very narrow. But the heart really won't get small for any particular reason. So, in a normally exposed chest, generally speaking, you can tell when the heart is enlarged or not. But there are artifacts. There are artifactual enlargement. Remember, I talked about the magnification because of the AP projection. So the heart may appear slightly larger on an AP projection, but I may not call it cardiomegaly because I know it's an AP view. The tech has told me it's an AP view, and so I'm going to be cautious. If the patient has a poor respiration or is on a ventilator, then the heart may appear to be larger than 50% of the cardiothoracic ratio, but really it's the patient just hasn't expanded their chest well. So that's an artifact. The patient may be slightly rotated, which makes the heart look larger. That's an artifact. There are some pathologic situations where the heart itself is not enlarged, but the shadow of the heart is enlarged. Let's remember that in this glob here is not just heart muscle and chambers, but there is a sac that the heart sits in called the pericardium. Now this sac is kind of like the pleura. It has a small amount of fluid in it, but But when it gets a lot of fluid in it, the sac will get big and will actually press on the heart. When the sac gets big enough and filled with fluid, it can actually compromise cardiac function. We call that cardiac tamponade, where it's actually squeezing down the heart and not letting the heart fill up with blood so that it can pump. But this sac, when it gets fluid in it, it's called a pericardial effusion. And pericardial effusion can give the appearance of widening of this diameter here, but really the heart itself is maybe normal. And then there's true cardiac enlargement, which, to my friend's point, may be secondary to dilatation of the chambers, where the muscle of the heart itself is normal in size, but the chambers just get dilated. Or the muscle of the heart actually gets thick, and the heart becomes enlarged because of the thickened muscle. We usually see muscular enlargement when the heart has to pump against pressure. So just like any muscle, when you exercise it, it gets bigger. If you have stenosis of the aortic valve, which is the valve between the left ventricle and the aorta, which is where all of your blood is going out to oxygenate your body, if that valve becomes stenotic and tight, muscle has to pump harder to push through that tightness. The left ventricle will become thick. Next year, on a slide, I will show you a pathologic section of a heart where the muscle is really thick, but not this year. So here's a picture of an enlarged heart. Here's the cardiothoracic ratio is clearly greater than 50% of the ratio of the diameter of the lower chest. So this is a general. I mean, on a frontal view, you can't necessarily tell which chambers are enlarged. There are ways to tell which chambers are enlarged on radiographs. I don't know that we really need to get into it too much. But here, notice this picture of an enlarged heart. And now look at this picture of an enlarged heart.
What?
They look a little different. Aside from that one being bigger. Look how the heart gets. Here it looks really normal, and then it gets just this huge, like, balloon shape. Whereas this one, it's definitely more gradual. This is cardiomegaly because of either enlargement of the heart muscle or dilatation of the chambers. Much more common than this one, which is the pericardial effusion. When I see this, I think of a balloon, a water balloon, right? You're holding the balloon again on a table, and I'm holding it up here, and it gets real narrow, and then the balloon is full of water, and it sits on the table. That's what that looks like to me. In the early days of chest radiography, there used to be these things called your grandparents may have seen a water bottle, like if you had low back pain, you put hot water in this thick plastic thing and rubber thing, and you put it on your back. This is called a water bottle heart or a water bag heart. Okay, but to me it looks like a water balloon, so I just think of it as a water balloon. But it certainly, I mean, you would look at that and go, wow, that heart's big. The heart is probably in here, right? Normal. This is all the fluid that's in the pericardium. Actually, that thing needs a needle. You need to get the fluid out of it because the patients will compromise their cardiac function. Shall we just go through the path of blood, or do you guys good with that? I mean, is that? I just want to make sure we understand the way the blood is flowing, right? So, deoxygenated blood coming in from the periphery, in the superior vena cava and inferior vena cava, into the right atrium. From the right atrium, it crosses the tricuspid valve, goes into the right ventricle. From the right ventricle, it crosses the pulmonic valve, goes into the pulmonary arteries, into the lungs, where it gets oxygenated, comes back into the pulmonary veins, and then the pulmonary veins, usually there are 4 of them, but there may be more, drain into the left atrium. So, deoxygenated blood, right atrium, tricuspid valve, right ventricle, pulmonic valve, pulmonary arteries, pulmonary veins, left atrium. Now we have richly oxygenated blood on the left side of the heart. Left atrium across the mitral valve into the left ventricle across the aortic valve into the aorta. Now richly oxygenated blood going out to the periphery. We all knew that. I just wanted to make sure that you guys had it clear. The thing to know about the coronary circulation is, as soon as that blood leaves that left ventricle and crosses that aortic valve, that's where the ostia of the coronary arteries are. So there are two ostia. Ostia means opening in Latin, okay? Two ostia, one for the right coronary artery and one for the left main coronary artery. And then there's a third cusp that doesn't have any artery coming out of it. And the right coronary artery then feeds essentially the right part of the heart and the base of the heart. The left main coronary artery divides into the left anterior descending, which gets the left ventricle, and then the left circumflex, which gets the back of the heart. So just so we're good with that. So right atrium, tricuspid valve, right ventricle, pulmonary artery. It's blue because it doesn't have oxygenated blood in it, and it's hungry for oxygen. And then here's the left atrium, and here's the ostia of two left pulmonary veins coming in across the mitral valve. The thick left ventricle, which is doing all the pumping. The left ventricle is always thicker muscularly than the right ventricle. This only has to push up against pulmonary pressure, which is about a third of the pressure of the left ventricle that has to push up against the entire body. Pushes it out the aorta, and then there we go. And then you can't, this is a cusp, but the coronary artery ostia will be in here, feeding the heart muscle itself. So a valve can be normal, it can be stenotic or tight, it can be regurgitant or loose, where normally the blood goes through the valve when the chamber contracts, the blood goes through the valve and then closes when the chamber relaxes. And then, but if the valve is not functioning properly, the blood can go through the valve, the valve doesn't close properly, and blood sloshes back into the ventricle that it came from. That's called regurgitation. The valves can have vegetations on them. The chamber, the right ventricle, the left ventricle, the right atrium, the left atrium can be normal in size. It can be dilated because the muscle is baggy and not working. It can be restricted because the muscle is either diseased or too thick, or it could have a thickened or thin wall. So just a real quick one on that. When the heart muscle responds to increased pressure, the muscle is going to hypertrophy. The muscle is going to become thick. There's going to become more muscle, just like your biceps hypertrophies when you do curls all the time. The response to increased volume is for the chamber to dilate, but the muscle will not get thicker. Okay, so how do you get increased volume in the heart? Well, if your heart isn't pumping properly because the muscle is diseased and the volume of blood is backing up into the chamber, and because the chamber won't empty every time the heart beats, that chamber will slowly dilate to accommodate the higher volume of blood. And unfortunately, these chambers just don't dilate alone. If the left ventricle dilates, the left atrium is ultimately going to dilate. And when the left atrium dilates, ultimately the right ventricle is going to dilate. And then the right atrium is going to dilate. Then you're going to have four-chamber dilatation. I showed you this before. I'm going to show you it again because it's kind of important. The two anterior chambers are the right atrium and right ventricle. The two posterior chambers are the left atrium and the left ventricle. And we know what forms the borders of the heart. I said it last lecture, so I won't say it again, but I just want to make sure that we are all aware that this is important. Okay? Posteriorly, the posterior margin tends to be the left ventricle and the left atrium. Anteriorly, the anterior margin tends to be the right atrium and the right ventricle. These are the moguls. I know we kind of went over it before, but I'll go over it again. The right atrium, here's the ascending aorta. It's drawn incorrectly. That's a pulmonary artery. But the ascending aorta and SVC kind of blend together. Then there's the aortic arch. The pulmonary artery sits out here. Usually the left sits over here. And then there's a left atrial appendage, which you never see unless it's diseased, so I wouldn't worry too much about that. And the left ventricle is over here. So let's talk about congestive heart failure, because this is something you're going to see a lot. Now that we have an idea in our minds about how the blood flows and what we expect the chambers to do, the most important thing the chambers have to do is essentially pump an equal volume of blood on the right side and on the left side. So the blood that's going out of the right atrium and right ventricle pretty pretty closely equal the volume of blood going out of the left atrium and the left ventricle. Because if they get out of whack, then something's going to back up, right? And what usually winds up backing up is the blood backs up into the lung, and you get this. Then you get the increased pressure in the blood vessels in the lung, and when you get increased pressure, then you've got these basement membranes in the blood vessels of the lung, the small blood vessels where the gas exchange is actually happening. These basement membranes start to break down. So the serum of the blood starts to leak into that airspace, and you get this edema. But before that happens, the blood vessels start to dilate. So the blood, let's just say that someone has a heart. They have a myocardial infarction. It's on the left side of the heart. It's on the pumping chamber of the heart. So now the left ventricle, which used to pump equal volumes of blood with the right, now the left ventricle is diseased. It's only pumping out half the amount of blood that it should. So what happens? Pressure builds up in the left ventricle and in the left atrium. Blood is trying to get into the left ventricle from the left atrium, but the left ventricle can't pump it out fast enough. So blood starts to back up into the left atrium. It starts to back up into the pulmonary veins that are delivering blood to the left atrium. The pulmonary veins start to dilate. It starts to back up into the capillary beds where the gas exchange is actually happening. So now the right heart is starting to realize that, hey, I can't send up enough blood into the lung because all this pressure is backing up because the left side isn't doing its job, okay? When the left side stops doing its job, the right heart can't pump blood into the lung enough. The pressure starts to go up. And when the pressure starts to go up, the basement membranes start to break down. Fluid starts to weep into the lung alveoli where the gas exchange starts to happen. And now we've got this pattern of edema in the lung. And when it starts early, it's called a bat wing appearance, and I'll show you. Remember, all the vessels are in the middle, right? All the big vessels of the pulmonary veins and pulmonary arteries are on either side of the heart. Well, that's where you're going to see the edema start first, okay? So these plump vessels will then start to get plumper and plumper, bigger and bigger centrally, and then bigger and bigger in the periphery. And then you'll start to see this edema pattern happen. When it gets really bad, you can get really bad airspace edema, and it looks like pneumonia. It looks like consolidation. It looks like all the other diseases we were just talking about in the last hour, in a couple of hours. So here I've got. Who would say that heart is big? The heart is big. Okay, got a big heart. I've got this pattern of big vessels central. I've got a big heart and big vessels centrally. And I seem to see a lot more vessels than I was seeing on the normal chest x-rays before, right? There just seems to be more. What else is there?
Blunted costo.
God bless you, my friend. You said that. Right. I was just going there. You see, there's this thing laterally where there's a costophrenic angles are blunted here and here. Okay. Posteriorly, on the lateral, remember this is the front of the chest here, this is the back. On the lateral, I've got this kind of meniscus sign here. So there's fluid building up in the pleural spaces. Why? Because the heart can't, the right side of the heart and the left side of the heart are not pumping out the same volume of blood. Something is wrong. Either the entire heart has just stopped pumping enough, or there's a mismatch. And blood and serous fluid is now backing up in the vessels. Another thing that we like to see on the chest radiograph is those interstitial tissues also have blood vessels in them. And the interstitium of the lung the blood vessels in the interstitium start to dilate as well. And they get these perpendicular lines in the periphery, kind of like there. You can't see it real well here. But these lines are called curly lines, not after the guy in the Three Stooges, but after some other guy named Curly. And this is fluid that's building up in the interstitium and around the blood vessels. So you get these curly lines. You get fluid in the major fissure and the minor fissure. This is not a great example, but you got this fluid that's going all the way back to the hilum, a little bit of fluid in the minor fissure on the right. And you've got the pleural effusions. You've got the meniscus sign. So these several signs are signs of congestive heart failure. What are they? Back wing central edema. And bat wing central edema. I think I might have another picture of bat wing, which really looks like a bat wing. Okay. Cephalization of the vessels. Curly lines. Fluid in the fissure. Pleural effusion. You see all those things together and a big heart, it's congestive heart failure. Any questions about CHF? Let's talk a little bit about what might predispose the heart muscle to stop beating well. The heart is a muscle that needs blood. I've said that the origin of the coronary arteries is, and that it's getting the most oxygenated blood it possibly can get because it's coming right out of the left ventricle. The blood goes across the aortic valve and right into the coronary cusps and into the coronary arteries. But when those coronary arteries get clogged up, or when something compromises the blood supply to the coronary arteries, then the heart muscle itself becomes starved with blood. You know, one would think that the heart is filled with blood, and gee, why the heart muscle should just be able to absorb that oxygenated blood right out of the chamber. It doesn't work that way. Just like your spleen is fed by an artery, your heart is fed by arteries, and those arteries need to be open. And when they're not, it's a problem. This is coronary artery disease. When the plaque builds up in those vessels to the point where the plaque ruptures and includes the vessels, then you get acute coronary syndrome, ACS. Acute coronary syndrome, that's acute myocardial infarction. Now, luckily, we have lots of different ways to see the lumen of the blood vessels, the heart arteries, so that we can predict when the heart arteries might occlude, and then we can actually go in there and prevent them from occluding by putting a stent in or doing a bypass on those folks. So lots of different ways to do that. One of the ways we actually can use CT, CAT scan, to predict whether people will have a coronary event in the future is to actually measure the amount of calcium in the blood vessels. This is called a coronary artery calcium scoring, and it's something that's done not infrequently these days, especially with people who are otherwise healthy, who want to know what their likelihood is of having a coronary event. And what we do is we actually measure the amount of calcium in the blood vessels. And we've been able to show that there is a loose association between the amount of calcium and the likelihood of a coronary event in the next several years. So someone who has a high coronary artery calcium score would be the kind of person who might go on to do other stress testing or other testing to see if they have significant coronary artery disease that might need repairing before they get a heart attack and before they get heart muscle damage. Another way we can look at the heart muscle itself is to use ultrasound. Now, I'm just going to tell you that my fellowship after my radiology residency was in ultrasound, CT, and MRI. So I love ultrasound. Ultrasound is great. But the first time I ever looked at an ultrasound picture, I thought I was looking at a weatherman. Okay, I had no freaking idea what I was looking at. And so I'm going to show you some ultrasound pictures. I am not going to put any ultrasound pictures on your test. Okay, would never do that. But you should know that echocardiography is a method of looking at the heart. Okay. So what I have here actually is a picture of an echocardiogram. The patient's skin is up here. The beam of ultrasound is this thing. And what I'm able to see is that I've got a short axis view of the heart muscle itself, and that there's a chamber here. Okay, enough of that. So, but what I can do with that ultrasound is I can watch the heart beat in real time. I can actually see the muscle move, and I can see the chambers empty and fill, and I can do a lot of measurements of that. It lets me look at the valves. Okay, actually, this is actually a leaflet. This is the anterior leaflet and the posterior leaflet of the mitral valve, and this is the valve opening. This is during the time that the blood is crossing the valve. So this is the valve in action. The beauty of ultrasound is you can actually watch it in real time. We can do ultrasound by putting a probe on the chest. We can do ultrasound by sliding a probe into the esophagus and putting it behind the heart and looking at the heart that way. That's actually it's a quite nice way to look at certain parts of the heart that you can't see from the chest. That's called a transesophageal echocardiography. Now, the stuff we're doing now, the stuff I'm talking about now is really almost like this, it's just kind of like show and tell. So I'm giving you some ideas of where the kinds of things we can do to look at the stuff that we're doing. So here's another picture, here's another echo, 4-chamber long axis view of the heart. Again, patient's skin is up here, so the closest, you can always, put your hand on that spot, put your finger on that spot in your chest where you can actually feel the left ventricle hopping up and down against your chest wall. That's right here, the apex of the heart. So there's the left ventricle, there's the interventricular septum and the right ventricle, here's the right atrium, here's the valve, here's the mitral valve, here's the left atrium. So you can see exquisite anatomy there. You can use color Doppler to watch the flow. This happens to be an incompetent valve where the flow is going away, which means that the valve is diseased and open, or regurgitant, as we say. We can use nuclear medicine to tag a certain kind of chemical that is tagged to an isotope. And we can inject that chemical into the bloodstream. That isotope and chemical are taken up by the heart muscle. And as the heart is beating, we take pictures of it with a nuclear camera. Then we take the patient and we put them on a treadmill and we have them exercise. And we inject them again with the same stuff. And we see where the heart, and we compare the two sets of images. And we see where the heart muscle is not getting blood during exercise. From that, we can infer that the patient has coronary artery blockage or disease significant enough to prevent blood from getting to their heart muscle when they're exercising. So we may have all seen older folks who get winded and tired when they walk up a flight of stairs or can't. Some of those folks have coronary artery disease and their heart just isn't pumping well enough. But we can identify with nuclear medicine exactly where the blockage might be, predict which distribution of the heart muscle is not getting enough blood. And then we can go and take that patient to catheterization, identify the blockage, open up the blockage with a stent or something like that. So myocardial perfusion, SPECT, which is a word that means single photon emission computed tomography, which is what this thing is. It's a SPECT image. Can be done at stress and at rest. Again, just another way to look at the heart and to evaluate the heart muscle. Well, what if I want to look at those heart arteries directly? I don't give a crap about all this other stuff. I want to see, is there a blockage in the vessel or isn't there? Well, that's when we do the coronary artery angiogram, which still remains the gold standard, really, for evaluating coronary artery anatomy and potential blockages. So what happens? You go into the cardiac cath lab, you get stuck with a needle in your groin artery and your femoral artery. Through the needle goes a wire, over the wire goes a dilator, over the dilator goes a sheath, and then through the sheath goes a catheter that is worked up into the aorta, into the chest, across to the aortic valve, and then slips into the ostium of that coronary artery, and you inject an iodinated contrast, and you start taking 30 frames per second of video fluoroscopy, where you're looking in real time, you're injecting the contrast, you can watch the contrast fill the entire coronary artery and its distribution, and then you can identify where the blockages are. So what happens is, this is the normal one on the right, actually, this was after we did what we had to do, but here's the catheter, it's sitting in the coronary artery ostium right here. You injected the contrast, which is white, okay, because it has iodine, which is radiodense. And now you can see that this is the normal anatomy. But over here, when we did it before, here's the catheter in the artery. You can see that this vessel fill and this vessel fill, but something was missing here. Something is missing. Now we opened up that blockage, and we put a metallic stent in that short blockage, re-injected, and now you can see that the flow has been restored in the distal coronary artery. So when the patient was in the cath lab, looking like this, they were in the process of having a heart attack. And this is what happened after they put the stent in. This happens every day. And it's really quite a miracle of modern medicine to see it in action. I was able to watch my own mom have a complete right coronary artery occlusion. You know, she called me up, she said, I'm having chest pain, took her to NCH. My buddy, the cardiologist, said, let's get her in the cath lab. She was in the cath lab for an hour, they opened her up, she had 0 heart muscle damage. I mean, this happens all the time. So it's really important when your patients, when you see these patients with, you know, EKG abnormalities, chest pain, you know, all the classic signs of myocardial infarction. They need to go. They need to go to the cath lab and get taken care of. So there are other ways now to image the coronary arteries. And over the last several years, we've been using CT, computed tomography. Basically, we inject, instead of snaking a catheter up into the coronary artery, now we just inject in the peripheral vein. We time it perfectly with the help of the machine, and then you take very, very fast, very, very thin section pictures of the heart while the contrast is filling the heart arteries. And the computer creates these beautiful images of the heart. This is just like a surface rendered image of the heart. Shows that stent, which was placed. You can't really tell. You got to kind of know it's there. What's that stent? It's there. But we can do this now very accurately. But still, the gold standard is the catheter angiography. Why? Because if I do this, I can only diagnose the blockage. I can't fix it. When the catheter is in there, we can actually, the cardiologist actually go in there and fix it. And that's what we want. Okay, so let's leave the heart and let's go to the aorta, which is that big tube that comes out of the heart that brings blood basically to the entire body. We've got all these blood vessels that come off the aorta in the head and neck. The aorta goes into the abdomen, got all these blood vessels that feed all the solid organs in the gut. And then the aorta divides, and we got blood vessels going into the legs, right? So the aorta is kind of important. The good thing is that we can evaluate the aorta with just about every modality we know and evaluate it well. This whole process of atherosclerosis that involves the coronary arteries can also involve the aorta, and it could cause the aorta to dilate. We call that an aneurysm. And that aneurysm can become very large and can rupture. When an aneurysm of the aorta ruptures, it's usually lights out for the patient, okay? However, we can identify that the rupture is occurring, and in some cases, we can get that patient to an OR and fixed before they exsanguinate. The aorta is made up of several layers, and if blood happens to work its way out of the inner lining of the aorta, because the inner lining becomes atherosclerotic and diseased, and blood actually can force its way out of that inner lining and between the layers of the aorta. That's called an aortic dissection. And when the aorta dissects, it's usually not a very good thing at all. It can be treated medically, not necessarily surgically. And if you can maintain the patient's blood pressure in a normal range, people can live with a dissected, chronically dissected aorta. But they have to be monitored very carefully. If the aorta dissection involves the ascending aorta right out of the heart, the part that goes up, that's a surgical emergency. Why? Mostly because it will compromise the coronary artery circulation, or it will compromise circulation to the brain. But if the dissection only involves the descending thoracic aorta, we can usually not have to operate on those patients and can control them with medication. And then there's the false aneurysm of the aorta, or just about any blood vessel, which is usually post-traumatic. And it's usually done in the aorta when we see these pseudoaneurysms. It's usually high-speed motor vehicle accidents where the patient has been thrown around the car. This is the greatest reason to wear your seatbelt that there ever was, because the traumatic pseudoaneurysm of the thoracic aorta is almost universally fatal and accounts for a large percentage of deaths caused by high-speed motor vehicle or plane crashes or things like that. It's the pseudoaneurysm tear of the aorta that kills you. So, in a normal chest X-ray, we're accustomed to seeing this really thin, kind of not very wide superior mediastinum. But in an older patient who's got lots of atherosclerosis and an ectatic aorta or tortuous aorta, you can see the ascending aorta gets really wide out here, and here's the descending aorta gets really wide. That aorta is just dilated and may not necessarily be aneurysmal, but it's just dilated and baggy and large, and it's been around a long time. Here's a cartoon of this idea of dissection, where in the normal flow, You've got these normal muscular wall with a lining normal lining of the aorta. But if that lining gets ruptured for any reason, it's usually because of atherosclerosis, then that blood under significant pressure. Remember that the pressure in the arterial system and the systemic arterial system is what, 140 millimeters of mercury, 130 millimeters of mercury, even higher. So that pressure is significant and it's easily able to dissect between the layers of the aorta. We generally see these aortic dissections causing a false channel. Here's the true channel, the true lumen. Here's a false lumen, generally in older people. Happens to be rather more common in patients with Marfan syndrome, which is a connective tissue disorder that some famous people have had Marfan syndrome. And right off the top of my head, I can't remember, but next year I'm going to tell you because it's in the slide. Those patients tend to have, all patients with dissections tend to be atherosclerotic and have hypertension, but it does have a high mortality. It really has to be observed, has to be caught, may need to be repaired, but may not necessarily need to be repaired. So here's a CAT scan through the aortic arch in the chest. Here's lung, it's black. Okay, here's bone, it's white, scapula. This is the anterior chest. This is the patient's back. And the patient has been injected with an iodine contrast material to outline the blood vessels. It's white. Okay, this is the aorta. But notice how the aorta has this line through it. This is the flap. This is the false channel. This is the true channel. So we went here. This is the false channel. This is the true channel. This would be the flap. Okay. And so this thing just dissects the entire length of the aorta. You can see on the coronal view. Now this is axial. This is as if you were in a bologna slicer, right? This is you in a slicer. This is you. This is as if I was looking at you, but I was looking through you directly. So your head's up here, and here's your liver, here's your spleen, here's your kidneys, and here's your aorta. And then this particular section, I can see that the flap is up here, but the flap is also down here. It's just going through the entire aorta. Unlike this image, which is it's images that was taken during an angiogram, where the catheter was put into the aorta and iodine was injected. Now on CT scan, the iodine looks white. On this particular image, the iodine looks black. We don't have to go into why right now, but suffice it to say that here's the ascending aorta, and here's this big blob of something. And here's the descending aorta. This is that traumatic pseudoaneurysm tear, the high-speed MVA that tore the aorta. It always tears in the same spot. It always tears where the aorta basically is attached to the posterior part of the chest and the spine. Because when you're moving at 70 miles an hour and you hit something that is moving at 0 miles an hour and is really, really, really hard, like the bridge abutment, okay, your insides are going to move at 70 miles an hour until they stop. Well, when your aorta moves at 70 miles an hour until it stops, but it's fixed at one point, that's the point that it's going to tear. Okay, so this is the point that the aorta is always tearing. This is essentially a death sentence. In this particular case, they might have been able to get to the guy and put a stent across this before he bled out. But these people almost always die at the scene. It's really unpleasant. So now we're going to get out of the chest altogether. We're going to go to the blood vessels that feed the brain. This carotid circulation. We each have two carotid arteries, two common carotid arteries that divide into an internal and an external carotid artery, and it's the internal carotid artery, that's this one that goes up and feeds the brain. Okay? But that atherosclerotic process that happens everywhere, happens in the heart, happens in the aorta, happens everywhere, also happens here, and can cause this internal carotid artery to become blocked or narrowed, and that obviously is going to compromise blood flow to the brain, and the brain is a very important organ, so we don't want to do that. So we want to be able to identify when the carotid artery might be at risk. You might not have seen it yet or learned it yet, but in the physical diagnosis class that you will undoubtedly take, somebody's going to teach you to put a stethoscope on the neck and listen for a bruit. A bruit is the vibrations of blood flow that is not normal. Okay, blood flow that is being impaired by some kind of blockage. So if you've got a wide open pipe and that blood flow is what we call laminar, right? It's just going nice and smooth, nothing's blocking. But if you put something in that pipe to disrupt the blood flow, then the blood flow is going to become turbulent. And it's that turbulence which will cause this tissue around it to vibrate. You put that stethoscope on your neck, you're going to hear that vibration, called a bruit. Well, when you hear that bruit, you're going to order a carotid ultrasound because you're going to ask me to look at what's inside that blood vessel and tell you if it's blocked. And if it is blocked, how badly is it blocked? So we're going to want to look at that internal carotid artery. I don't really care so much about the external carotid artery, which feeds the face and the scalp. Yeah, the face and the scalp are important, but I really want to know what's going on to the blood vessels of that brain. So I'm going to be able to look with ultrasound, and I'll be able to actually look at the blood flow itself. Terrible, terrible slide. Patient's head is up here. Patient's foot is over here. This is the common carotid artery as it divides into the external carotid and the internal carotid artery. On this particular case, patient, here's the common carotid artery, here's the external carotid artery, and here's this stuff sitting inside the blood vessel. So this is echogenic plaque. I can actually go ahead and measure. I can look at the blood flow with color Doppler, and I can tell you if the blood flow is going in the right direction. Here I can tell you that there's something really major that's blocking this blood vessel, and then I can measure the velocities using the ultrasound machine, and I can tell you the percent stenosis of that blood vessel. What percentage of it is blocked? Generally, if it's under 50%, they're just going to watch those folks. 50 to 79%, they might consider surgery. Anything over 79%, they're generally going to say, hey, we need to go in there, open it up, and pull the plaque out, close it back up. That's called an endarterectomy. It's a pretty common procedure that lots of patients get. Here is just a tracing of the blood flow. Here's a heartbeat, but here's all the different velocities of blood inside the voxel that I'm actually interrogating. And I can see in a normal patient, the velocity is somewhere about 60 or 70 centimeters per second. But on an abnormal one, I can see the velocities are over 250 centimeters per second, almost 300 centimeters per second. So that's what carotid ultrasound is. I'm not going to we're not going to worry too much about this right now. Next year I will talk more about this stuff. But we have other ways of looking at the blood flow in the carotid arteries. And one of the ways is with MRI. Now, you probably all think about MRI and you think about, well, it's for knees, and it's for lumbar spines, and it's for shoulders, and it's for brains, but it's also great for flow. And through a whole bunch of physics that we aren't going to talk about at all, I can make blood flow look white, and I can make a normal blood vessel, I can make a blood vessel appear out of the MRI data. And so here is the common carotid artery. Here's where it bifurcates. This is the internal carotid, and here's the external. Behind it is the vertebral artery that's in the back of the spine. And so I can show you blood vessel flow with MRI, and I can quantify it just like I can do with ultrasound. Flying right along. We're out of the brain, we're out of the neck. Now we're going to the abdomen. And we're going to talk about that aorta again. We talked about the aorta in the chest with the dissection. Now let's talk about the aorta in the abdomen with the aneurysm. The aneurysm means basically a dilatation of the wall. Now a true aneurysm is a dilatation of all the layers of the wall of the vessel. A blood vessel, an artery, has several layers. There's a muscular wall. There's the adventitia, which is the outside. Then there's the muscular wall, and then there's the inner lining of the blood vessel. So a true aneurysm is a dilatation of all three layers, and a pseudoaneurysm is where two of the layers are normal, but one layer has become diseased. Not too much to worry about right now. But in this particular case, let's consider a normal aorta. Here's the spine. This is a CAT scan. Here's the spine, the vertebral body. Here's a kidney. There's a kidney. And here's the aorta sitting exactly where it should be, right on top of the spine. Contrasted with this guy, here's the spine, and here's this huge thing, which is a dilated aorta, which has, here's the blood vessel, the blood flow, which is white, which is that iodine contrast material I put in there, right? Here's the white blood flow, and this is the flowing blood, but this is all thrombus, this is all blood clot, essentially, sitting here in this big dilated aorta. This thing is just ready to rupture, okay? And when this thing ruptures, it's over, okay? Because as you can imagine, the aorta is carrying a hell of a lot of blood. And for any unit of time, there's a lot of blood being pumped in the aorta. So if this thing ruptures and starts bleeding into the retroperitoneum, it's going to bleed a lot. But by the time you find it, the patient is exsanguinated, okay? So we really want to find them when they're much smaller than this, so they can be fixed. Let's look at another blood vessel in the abdomen that can be stenotic, just like the carotid artery can be stenotic. We can do the same thing for renal arteries. Renal arterial stenosis can cause hypertension. And usually when your hypertensive patients are not being controlled by medication is when you should start thinking about this. It's not a very common cause of hypertension, but it is a fixable cause. So what happens is when the blood flow to a kidney gets compromised, there's a very complex pathophysiologic mechanism that goes into effect. The kidney is an organ that just absolutely must have a certain volume of blood for any given unit of time. And if the kidney doesn't get that blood, it starts sending out hormonal signals, okay, that says, I want blood, and I insist, body, that you increase your blood pressure to get me blood. I don't care what you have to do, but you're going to get me some blood. So the kidney starts secreting angiotensin and other stuff, and your brain goes, my kidney is not getting enough blood, I have to increase the blood pressure. So your systemic blood pressure goes up because the kidney's not getting enough blood. And the kidney's not getting enough blood because something is blocking the kidney artery, the renal artery. And so we will, it's usually atherosclerosis, but it can be something called fibromuscular dysplasia. Not a big deal to worry about, and I don't want you to have to worry about that. But there are many different ways we can evaluate whether or not the kidney is getting enough blood. And one of the ways is with MRI, again, showing the blood flow using MR. And when we can identify the stenotic segment, then we can fix it with a stent, just like we did in the coronary artery or elsewhere. So here's an MRA, magnetic resonance angiogram. Okay, no catheter was used, no contrast dye was administered, although you can give dye. I'll say the word dye today, but next time we talk about this, I'll use the word contrast. You can give a certain kind of MR contrast that makes this look more pretty, but I can create a map of the blood vessels just using MRI. And here you can see this is the left kidney, this is the right kidney, and this would be the splenic artery, and this is the right renal artery, but the left renal artery is very narrow. And so here I would then say to you, who ordered the study, I'd say this lesion is amenable to percutaneous angioplasty, where you then put a catheter in here, put a wire across the blockage, put a catheter across the wire, and then use the stent in the catheter and blow it up and open it. So we've gone from the aorta, looked at the kidneys, now we're going to keep going down into the legs. What happens when that atherosclerotic process involves the arteries that lead to the legs? Then we get this thing called claudication, which is pain on ampulla, usually. Or when it's really bad, rest pain in the legs. A lot of older folks get pain. They can only walk 2 blocks. They can only walk, 1 block, and then they have to sit down. Their legs are tired. Their legs are heavy. Their legs hurt. Or when it gets really bad, their legs hurt all the time. They get a wound on their foot and they can't heal it, okay? They're diabetic and the peripheral blood flow becomes diminished. So this thing called rest pain is something that we really want to be cautious of, and it's telling us there is something going on with the blood supply to the lower extremities. Well, how can we assess that? Well, we can assess it with just about everything I've already talked about. The only thing you can't really assess it with is just a plain x-ray. You can see calcium in the wall of the blood vessel. The blood vessels, the femoral arteries that lead to the legs, but it doesn't necessarily tell you if those blood vessels are occluded or stenotic. So we want to look with ultrasound. We can infer whether or not the blood vessels are stenotic or not by looking at the pressure waveforms in the legs. Or we can do an MRA, magnetic resonance angiogram, or CT angiogram, or a conventional contrast angiogram where we use a catheter in the blood vessel itself. This is called a non-invasive peripheral vascular arterial study, where we basically put big cups around the thigh, around the calf, around the feet. And as the blood is being pumped into the legs by the heart, the cuffs will actually measure the pressure difference in the leg. And we can actually make a tracing of the pressure differences. And we can see that that looks a lot like a cardiogram. And I can tell by looking at this whether or not there's significant blood flow disturbance to the vessels at each level. Not to worry about this, just to show you that it's a way that we can do it. But here's a conventional contrast angiogram, kind of like that carotid artery thing I showed you, where here's the contrast is shown entering this is the distal aorta, this is the common iliac artery, and this is the external iliac and the internal iliac on the right. But here on the left, here's the common iliac artery, and there's a big occlusion here, and there's a vessel that belongs here. This vessel is gone. This external iliac artery, that's the vessel that feeds the left leg. It's completely occluded. So I can tell very clearly that I've got to go in there and fix that. Here's an MR angiogram of the lower legs, okay? The knees are right here. This is the superficial femoral artery on the normal left side. Here's the popliteal artery, and then it divides into 3 vessels in the calf. Well, on this side, you can see that I've got only 2 vessels. I got 1 vessel here, I've got this, and then I got nothing. So I've got some significant peripheral arterial disease in the lower leg on the right. All right, we're almost done. We're going to be fine. So we've gotten all the way down to the leg. We've gotten all the way through the arterial system. But the blood's got to get back home. It's got to get back to the heart. It does that from the veins, of course. But what happens when there are veins that are clotted in the leg? What happens? The blood can't get back. That is a problem. It's a problem for a couple of reasons. It's a problem because the patient's legs swell and become painful. When would it happen that a patient's veins would just clot up? Well, there are a number of vascular states where the blood becomes hypercoagulable and starts to clot. And that's usually what causes these blood clots that occur. If a patient is very debilitated and doesn't move and is in bed a lot, the blood will just pool in the veins. Remember, it's the calf musculature, your act of walking and standing and living, that is actually pushing that blood back to your heart. So you really do need to be active and mobile. When you're sedentary, the blood can pool in your calf veins and start to clot. And when blood starts to clot anywhere, it tends to propagate along that vessel. Clotting blood is one of the most amazing physiologic chemical reactions that you can possibly imagine. Once it's triggered, it will go like wildfire. And so once you start clotting blood in your calf veins, it's going to start working its way up your leg and into your pelvis. And that's not a good thing because now blood can't get back to your heart. So we have this thing called Virchow's triad of blood flow stagnation, abnormalities of the wall, hypercoagulable states, causes the legs to become edematous, pain, redness. But when you see that in your patients, the first thing you're going to do is say, I need to know if there's acute clot in these veins because we have to treat that with a blood thinner, Coumadin, Lebanon, whatever. So, so we do this ultrasound test to look at the blood, at the veins. So we can not only see the veins, again, ultrasound, completely, you have no idea what you're looking at. But here's a round black hole, and here's another round black hole. This is an artery, and this is a vein. The nice thing about veins is they are very compressible, right? An artery wall is very thick with muscle. A vein wall has no muscle to speak of. So you can press on that vein and make it collapse. So in this particular case, I pressed on the vein, and I make the vein go away, the artery is still there. What does that tell me? It tells me there's nothing in the vein that is blocking at that level. So we do this test where we just march down the leg, we look at the deep veins, we go into the calf, we measure the flow in the vein, and we press on the vein to make sure they're compressible. In this particular case, the blue is showing you flowing blood, but there's something sitting in the vein, partial thrombosis that is partially occluding the vein. So what happens when these clots occur in the veins. They can break off. And if they break off, where are they going to go? They're going to go to the lung. And this is called the pulmonary embolus. One of the most common reasons why we do CAT scans of the chest in this day and age is to look for the embolic clot now in the pulmonary arteries. Okay, that's now the clot has come up the leg, gone into the inferior vena cava, gone into the right heart, gone through the tricuspid valve, into the right ventricle, and pumped into the lungs. But if you pump this clot into the lungs, it's going to get stuck in the smaller blood vessels. And if you stick that clot in the smaller blood vessels, then the lung behind it can't get any blood. And when the lung can't get any blood, it starts to become necrotic and dies. And if you get enough clot blocking blood flow to your lung, you can't oxygenate. And so you're going to become hypoxic, and you're going to be breathing hard, you're going to have chest pain, and it's a very common thing. Up until the last 20 years, we had very inaccurate ways of identifying PE, pulmonary embolus. It was almost a diagnosis of exclusion. Killed a lot of people because we had no good way to find it. So the clinical exams and the early imaging exams for PE were not particularly good. Now, however, we're much better at it because you're going to be taught, just like I was taught in medical school. If you think PE, then you have to exclude PE because it is a disease, it is an entity that will kill people. So it's not a it's not a diagnosis you can make on chest X-ray. In the days past, we would have patients breathe in a radioisotope, and we would be able to map their lungs, their breathing, okay, how much air is getting in their lungs. Then we would inject them with a radioisotope that was attached to albumin. And we would then map how much blood was getting to the lungs. And we tried to figure out what parts of the lungs weren't getting blood flow, so that we could say, yeah, this part of the lung has an embolus because that part of the lung is not getting flowing blood to it. Well, it sounds easy in theory, but these things are called VQ scans, ventilation perfusion lung scans, and they are notoriously difficult to interpret. They're very subjective, and they're not very accurate. About 20 years ago, we started figuring out if we inject enough IV contrast and take really fast CAT scan pictures of the chest, we can actually see the clot in the arteries themselves, in the pulmonary arteries. And so as our machines got faster and our computers got better, we were able to build CAT scanners that now can scan the entire chest in 1 second, 2 seconds, and see the entire chest. And if I time it right, I can get that pulmonary artery completely opacified white. And I can see the clots that are blocking the pulmonary arteries. And those are called CT pulmonary angiograms, and that's what we use today. We also, in the old days, we used to have to snake a catheter into the pulmonary arteries, which is hair-raising because you have to go across the heart to do it. You have to put a catheter in a vein in the groin. You have to put it through the right atrium, across the valve, into the right ventricle, and then into the heart, and then into the lung. And when you do that, you can induce all manner of arrhythmias. I remember being a resident doing a CT pulmonary angiogram before we had CT, so doing a conventional pulmonary angiogram. The patient would go into V-fib, there'd be crash carts, and you're trying to get the catheter across the heart, and they're trying to save the patient's life. Oh, it's just terrible. It's a mess. We don't want to do that anymore. This is what that ventilation perfusion lung scan looks like. The patient breathes this xenon gas that is radioactive, and then you take pictures. And then you inject the patient with macroaggregated albumin tagged to technetium, which is a isotope that we use. And all the white stuff here, notice how that looks like a heart? Well, that's the white stuff is the macroaggregated albumin radioisotope in the lung. And so you can see that there, that's perfectly normal. All the lung segments appear to look normal. Here's the same thing with a big cutoff here. This lung is completely occluded. There's no blood getting to that part of the lung. Who wants to look at that though, when you can look at this? Here's a CAT scan. Here's the main pulmonary artery. This is the left pulmonary artery, and there's this big clot sitting in it. I mean, it's beautiful. I don't want to look at that garbage. I want to look at that, showing you the clot perfectly. So this is exactly what you want to see, and this is what we do all night, every night. I'm what's called a teleradiologist. I work from home. I I used to be the chairman of radiology at Naples Hospital, was in private practice for 15 years. 10 years ago, I saw the light. I can do all this from home in my own house. Why would I want to go to a hospital? Okay? So for a number of years, I worked at night, and I worked in the middle of the night from my home, and I was sent these scans from all over the country. And so this is what I would see night after night, case after case. Rule out PE, rule out brain hemorrhage, rule out this stuff. Now I'm one of the medical directors of the company, so I don't do it nearly as much. But this is why this is because we do this stuff all night. Every ER in the United States is pumping out stuff like this all the time because they're so dependent on imaging now to make these diagnoses. And this is a classic example of how imaging has just saved so many people's lives. Here's another example. This is here's the pulmonary artery with contrast material in it. Here's the clot sitting in the left upper lobe segmental pulmonary artery. Here's the clot right there. All right, the last couple of slides, I just want to talk about, we have so many different ways of accessing the arterial and vascular system. We can do so many different things, and this is generally in the purview of the interventional radiologist. Now, there are physician assistants that work in radiology. Many states allow physician assistants to be in radiology. There are a few dedicated radiology physician assistant programs in the country. The day may come when one of you are just find that you love radiology so much you want to be a radiology PA. You could get to do a lot of stuff. You actually can't interpret images, but you can do a lot of the interventional stuff that we do, that are interventional radiologists, putting in lines and things like that. But we do all kinds of venous access. Our interventional radiologists do all kinds of venous access where we get percutaneous lines, tunnel catheters, ports in the central venous system. We do a lot of arterial work. That is, when an artery is blocked, we will put a catheter in there and open it up. To be perfectly honest, a lot of that has been taken over by cardiologists and vascular surgeons in the last 20 years. We put filters in the inferior vena cava to prevent clot from getting from the legs into the heart and the lungs. We embolize vascular bleeders, patients who have multiple trauma and get pelvic hemorrhage. We'll go in there and we'll put a catheter in the vascular segment that's bleeding. We'll embolize it with gel foam or some other stuff. We put these cool things in, and this is, I think, the last slide. Remember that abdominal aortic aneurysm I showed you? It was huge. In days gone by, the surgeon would have to open that abdomen, would have to put the patient on some kind of bypass, open the aneurysm, pull out all the crap, and pull a graft in, sew in a graft, while the patient's lower extremities are not getting any blood. Okay? Got to be a really good surgeon who can sew really fast and really accurately to save that patient's life. Well, now we can take a catheter, slide it across that aneurysm. Here's the aneurysm. Slide it across the aneurysm, and inside the catheter is a metallic stent that we then deploy and isolate the aneurysm. Now the aneurysm is it's not under any pressure. All the blood flow is now going through our vascular stent. And we basically save the patient a major operation and save the patient's life with this aortic stent. These are the kinds of things that interventional radiologists do. Yes, ma'am.
At what point do you decide to do the stent for an aneurysm?
It depends on the size of the aneurysm and the morphology. If the patient's bleeding, they're going to the OR because generally we won't be able to get to them in time. The surgeon has to get control of bleeding. Okay. Depending on the aneurysm's relationship to the renal arteries, if the renal arteries are involved, if you stent it, you might block the renal artery entirely, right? So that may require an operation. But I would say that the majority of abdominal aortic aneurysms are amenable to stent graft. We use these stents elsewhere, in the carotids, in the intracranial circulation in the brain, in the periphery, in the lower extremities. So interventional radiology is a very, very cool thing. I almost went into it myself. But in the mid to late 80s, I didn't really relish the prospect of being called in the middle of the night to be doing all this kind of stuff. I was kind of a sedentary kind of guy. So, but it's great stuff, and there's a lot of PAs. My company, we run a lot of radiology practices around the country. I'm the medical director of a number of practices around the country. And we love our PAs because they do great work for us. And radiology, becoming a radiology PA may be something that they might interest you down the road. And I know that is my last slide, so.